Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we are joined by Professor Yap Boom, the Deputy Incident Manager at the IMST based in DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Good morning, good afternoon, good evening. I'm happy to do the press briefing this afternoon on behalf of our Director General, Dr. John Kaseya, who is unable to take the briefing today. So 2 weeks ago, he was taking the briefing for the 1 year after the facts have been declared. And we do appreciate all the achievement that has been happening since August 2024. And this achievement has been done with all the colleagues from the IMST, from all the different partners, the member state in the field with a lot of passions. And also to you, the journalists, who have been following up every Thursday for a year now. So we really appreciate that, and then we'll be happy to give you some update on where we stand now on the response to Mpox and other outbreaks. Over to you, Director. As mentioned, it has been a year since we had been fighting against Mpox. Using that model of the IMST, which is co-led by Africa CDC, WHO, and more than 28 partners. And because of the efficiency of the model in responding to Mpox, 28 of state and government have decided to do a call for action. And this call for action includes 2 major components. The first one is the establishment of a presidential continental task force to elevate the issue of cholera at the highest level of the continent, to ensure that we have a multi-sectorial approach, which will include cholera not only as a medical challenges, but also ensuring that all the other sectorial, the finance, the planification, the minister involved on water and sanitation, and as mentioned, the President Hakainde Hichilema, also the Ministry of Local Government, to ensure that cholera really benefit for a multi-sectorial approach. So following their call for action, on the side of the task force, there was also the request to include the cholera within the Mpox IMST. And following that strong recommendation, the IMST, with all the partners, have worked tirelessly on developing the Continental Cholera Emergency Preparedness and Response Plan for Africa 1.0. And this plan has been launched in Lusaka, aside the RCWH meeting that was taking place in the presence of the DG of WHO, Dr. Tedros, Dr. John Kaseya for Africa CDC, Professor Mohamed Yakub Janabi, the RD for WHO, and Honorable Minister Elijah Julaki Mushima from Zambia. And this was with all the Minister of Health of the continent. So that was really an important and critical milestone on the path to elimination of cholera by 2030. So Africa CDC and WHO really plan to cut death, drive elimination, and boost preparedness across the continent. And that will happen with that strong leadership, relying on the technical expertise and also the solidarity to move closer to cholera-free in our continent. Next slide. So the 75th session of WHO Regional Committee for Africa, the SC75, was also the opportunity to have a number of side events, a number of engagement, all toward a stronger health in the continent. And that strong health in the continent includes the financing and the local manufacturing. As you all know now, for the time you have been following us, this is a key pillar for Africa CDC, the African manufacturing. It was highlighted once again, taking just one example of a vaccine. The continent is producing only 2% of the vaccine that we use, which is quite critical to push the agenda of African manufacturing so that we can move to 60% in the next 10 years or so. So it was an opportunity to reinforce the African strength, which lied in unity, but also solidarity. So it was important during the event to celebrate the vision, but also the champion, the AU cholera champion, the president of Zambia, and others, and also the institutions that are in place where action is needed, not tomorrow, but really now. Next slide. It was also the opportunity to celebrate Africa CDC and WHO. Our Director General, Dr. Jean Kaseya, has received the distinction of the Commander of the Order of the Eagle of Zambia. And in his remark, he directly mentioned how honored his was, but also that the distinction acknowledged the collective work that of the African Union and the Africa CDC in advancing health security. So this distinction goes to all the colleagues who are in Addis, in all the RCC, in all the countries working tirelessly to ensure that our continent is safer and healthier every day. And this definitely reaffirms a continued commitment to serving Africa with a dedication and humility. Next slide. Now, going back to our public health event, you still see the same top 4 of the event and outbreak that we have in the continent, led by cholera, as you can see in the number of suspected and confirmed cases, Mpox, which has the highest number of member states affected, followed by measles and dengue. And as you will see, the number of high-risk events, but also moderate, keep on increasing. And when you look at the ratio of what was happening in 2024, we can predict that most likely this year will have more events than we did have last year, which is also a consequence of many factors. We can name it the humanitarian crisis that is fueling some outbreak, including cholera and others, but also the climate change. We've seen how flooding have been impacting some of our country, leading to some epidemic and outbreak, including cholera, as mentioned already. Next slide. The situation of Mpox in the continent. We keep on seeing that decline. We have 76 decline in confirmed cases since the peak, with a sustained intervention to prevent the resurgence. So you can see, in the other hand, that the number of suspected cases have increased, which is a good indicator that the surveillance is going on, is continuing, and we have a lower number of cases. So that is giving confidence on the fact that the outbreak is really going down, though there might be some other epidemics going on, because when you have a high number of suspected cases, which turn out to be negative, that might be other disease, it might be measles, it might be others, which we are also trying to investigate. So the average weekly confirmed cases have also declined from 1,422 in the week 17 to 19 in the week 28. So we see almost 60% of reduction. The testing coverage, which has really challenged us, has also increased from 30%, which means that out of 10 suspected cases, we were only able to test 3 out of 10 people. But now we've moved to 55%, which means that at least half of the people that are suspected cases are actually being tested, which is also reassuring, though we need to move and get to the 80%, which is our target. The increased number of deaths is the major concern today, especially in Sierra Leone and Kenya, as I will be mentioning later. Next slide. In DRC, where we currently are as the IMST, you can see that the number of new confirmed cases keep on going down. We had 69 this week as compared to 93 a week ago. And the number of suspected cases are still increasing, which, as mentioned earlier, it's a good indicator that we keep on doing the surveillance, we keep on looking for the different alerts and performing the investigation. Now, what we are seeing, as already mentioned in the last few weeks, there is a shift. In the case that are moving to the Sankuru, Bawele, Tanganyika, which are actually the province that has been endemic for Mpox. So now we are also working with the country team to ensure that we adapt the response so that we go and contain and control the outbreak in those regions with the different intervention, but also with the vaccination, as I will come to that a bit later. So currently, 12 out of 26 provinces have been identified as hotspot, while at some point we were having more than 20 out of the 26 provinces that was really reporting high number of cases. Next slide. In Sierra Leone, the operation zero case by the end of August is still ongoing, and then we are gladly seeing that the case keep on reducing. We move from 43 to 34 cases this week, a 21% reduction. We also see the suspected cases that are also going down, and we are reassured by the testing coverage of 100%. Though the test positivity rate is around 59%, I think the active surveillance has managed to bring it down from 95% at some point to the 60%. And with the continuous operation, we believe that we'll be able to reach the 30%, which is the threshold that we have also assigned. The vaccination is also continuing with 43% of the people vaccinated that are contact, which emphasize the integrated approach that is implemented in the country, where the active surveillance, the community healthcare workers work hand in hand with the vaccinator, so that when they have one case, they can implement the vaccination, targeted vaccination around those. It's a good indicator and a good action to ensure that we control. Now, the challenge in Sierra Leone remains definitely the high case fatality rate. As you can see, this week we have 2 deaths on the confirmed case as compared to 3 last week, but it's still very high, especially when you compare to the number of new confirmed cases. A lot of action has been implemented with the partnership with NGO on the ground, but definitely with the investment of the government and the support of the IMST to ensure that this challenge of case fatality ratio is the highest in the challenge that need to be addressed. So we believe that in the coming weeks, we'll see more effort, though we also acknowledge that the population that are unfortunately dying of Mpox are already having some other comorbidities. 79% of them were suffering of HIV, which reinforce the need for stronger integration of HIV and Mpox, not only on the side of the sensitization, but really on the side of the patient management, where when we manage Mpox, we also manage the other comorbidities. Next slide. In Uganda, we continue to see the decline in the number of suspected cases and also the number of confirmed cases. Last week we were having only 10 cases as compared to 71 the previous one. So Kampala, Mbarara, and Wakiso remain the one accounting for the more than 60% of the case. And then it's important, and the vaccination also rollout has been started, I think, 2 weeks ago. Next slide. Burundi has been one of the very good examples of managing Mpox in the continent. Despite the small increase of cases that we've seen 3 to 4 weeks ago, we are glad to see that the confirmed cases are reducing despite the intensive and active surveillance. As you can see, with a test positivity rate of around 25%, it's a good indicator that the active surveillance is actually happening in the ground, so which is a good indicator. Now, out of 46 districts previously affected, 10 are currently reporting active cases, so which again confirm that the end They are moving toward the end of the outbreak, but definitely more effort are needed so that we can reach to the lowest number of cases as we also move to the transition and the integration of the Mpox in the national health system. Next slide. On the side of Liberia as well, we have a stagnation in the number of confirmed cases with a decrease in number of suspected cases. But you see, we've seen that sharp and exponential increase in the number of cases, which definitely is an alert, has been an alert on ensuring that we provide adequate support to the country. There is a mission that is planned to go and support the country in the next few days or the next few weeks. As you can see, the test positivity rate is very high. 96%. This means that the positive cases are the ones who come by themselves at the health facility because of their condition. So now the support that is critically needed, especially in the side of MODERATOR, that account for 64% of the total confirmed case, is really to boost the active surveillance so that we can go in the community and catch the case while they're there, but also support the vaccination so that around those cases we can implement the vaccination, and then we have the different action. The good news in the country is that the case fatality rate is still 0. They have not reported any death, and it's critical to carry on with that, with those good numbers. Next slide. In Ghana, we continue to see an increased number of cases from 44 to 52, which is also important to highlight the significant or exponential increase in the number of suspected cases. This indicates that the country has taken very seriously the active surveillance. And again, you can see the test positivity rate, which is quite low, around 70%, so which means that the surveillance is going almost everywhere to catch the positive case, which is quite important. So now the isolation of the positive case will support the country to limit the transmission, while the request for vaccination is also being evaluated so that they can also have this extra tool to ensure that they can control and contain the Mpox outbreak in the next few weeks. Next slide. In Guinea, we continue to see that exponential increase in the number of cases, though with 12% between last week and this week, where we have 87 confirmed cases. The test positivity rate is quite high as well, 70%. So the surveillance at the community level, it's not sufficiently implemented. We've been having some conversation with the country, highlighting some challenge on operational funding, which together with WHO and the partner will try to address and ensure that they had adequate support and fund to provide active surveillance. You are also seeing that most of the positive cases are actually hospitalized, which is a good indicator on stopping the transmission, though we definitely have some cases that are remaining within the community. So we need to have a different approach, and also need to support the country on working on their plan for the request of vaccination so that they have all the tools needed and available to contain and control the outbreak as we move toward that transition phase where we really want the Mpox to be part of the national health system. Next slide. In Zambia, we see the decrease in the number of cases and the number of suspected cases. Still, the clade 1B is the one that has been identified. The test positivity rate, around 27%, is also reassuring of the good surveillance that is happening. Now, it's important to note that Zambia reported its highest number of confirmed cases within the last 6 weeks as compared to what was happening before. The place of Copperbelt, Muchinga, and Lusaka province collectively account for nearly 60% of the confirmed case, highlighting them as the most affected region compared to others, which means that's really where we need to put all the effort to support the country to control the outbreak before it's going out of control. Now, 11% of the listed contacts tested positive, which is a good indicator of the capacity to actually target the right contact. We've seen in many countries where out of the contact, we have no person that turned to be positive. Here we can see that at least 1 out of 10 contacts are turning positive, which means that they are actually managing to get the right contact. By that, we mean that the stigmatization make it very difficult, for one example, for a sex worker or truck driver to actually identify their contact. So seeing that result is also a good indicator of the surveillance that is being implemented in the country. Next slide. In Kenya, this week, we see a decrease around 44% in the number of confirmed cases, though the number of suspected cases remain pretty stable. It's important to appreciate those efforts, especially knowing that Nairobi were coming at the 3rd position in the number of cases, with 8% of the cases after Busia and Mombasa. The rollout of the vaccination is planned for the next week, I believe, and it will help the country to go in those hotspots where they've identified the case and ensure that vaccination is implemented in the targeted approach. A support will be provided by the IMST to ensure that the strategy that has been tested in different places in Uganda, in Sierra Leone, and even in DRC can be applied, and the lesson learned also benefit to the country, which will have a better efficiency. 3% of the contact tested positive for Mpox. It's low, it's less than the Zambia as we see, but it's already something as compared to some of the country where we actually have 0% of the contact coming tested positive. Next slide. In Togo, we happily see the decrease of the number of cases. We moved from 2 cases to 1 case this week. And the peak period occurred a while ago. So the country is monitoring, it's surveying, especially the hotspot where they've been seeing the cases. So from 619 contact tested for Mpox, only 5 became positive, which is a rate of 0.81%. And 9 health districts are currently in epidemic, with the Gulf, Aguenie together accounting for 76% of the total case. When we highlight those places, it's also the opportunity to ensure that all the activity, or most of them, are really focusing on the hotspot. Next slide. Now, moving to the vaccine delivery and implementation, we've reached the bar of 1 million doses of vaccine that has been administered. That's combined the 972,000 of MVABN and the 39,000 of LC16, as I will show later, that has been administered in DRC. This is out of the 3 million doses that were delivered in 12 countries. So today, 18 countries grant the regulatory approval for MVABN, and 2 countries consider person under 12, because we've also seen that children are also affected in many countries. Now, we have, remember, around 260,000 doses of vaccine that has been made available. 7 countries were allocated the vaccine. And as we do speak now, 5 of them, Malawi, Ghana, Sierra Leone, Uganda, and Guinea, have made all the conditions for shipment. The two remaining will most likely have them achieved next week. And then they will be able to receive the vaccine in the next coming weeks, which is a great victory. But we are not yet there, because remember, we were planning to have 6.4 million of the vaccine for the entire continent, looking at the country in outbreak, but also country where it's endemic. Remember what I was talking about DRC, the shift that we are seeing currently are moving toward the provinces where Mpox were endemic. So we definitely need to provide some vaccine in those regions. Next slide. In DRC, where we stand, once again, the LC16, that is the produce of a collaboration between the government of Japan and the government of DRC, that has availed 1.5 million doses of this vaccine. The vaccination has started. 38,000 people and 967 has been vaccinated in Kinshasa, in the 5 health zone of Kinshasa, Equateur, but also Chuapa. So now the next step is to move out of those regions and to ensure that they can contain. The challenge with that vaccine, and that's why you see 30% wastage rate, is that when you open one vial, you need to vaccinate 250 people. So sometimes it's not possible to have all of them at the same time, but that's also reinforced the need for the risk communication and community engagement to ensure that the people who are most at risk, exposed, or targeted are present at the same time to increase the use of the vaccine. Next slide. From Mpox, we moved to cholera. And as I mentioned to you, we were really happy to have the launch of this continental cholera Emergency Preparedness and Response Plan for Africa 1.0. As you can see, the number of total cases of cholera has doubled more than double actually, between 2022 and 2025. The number of member states affected moved from 15 to 23 in just 3 years. So this has actually led to our leaders to do that call for action and to ensure that we have a different way of addressing the issue of cholera, using the lesson learned from the Mpox for the next 6 months, but also having the leadership at the continental level with the presidential task force that will ensure that we have the multi-sectorial approach. Because once again, there is no way that the ministries of health and their partners in country will be able to solve the issue of cholera. It's more complex because it needs more actors, especially in countries like Sudan, where the humanitarian crisis is also preventing the humanitarian actor to actually reach the communities. Next slide. Now, specifically looking at the countries, we see the decrease in the number of deaths and cases in Congo, the other side of the river. The hotspots are the Mbamu, Madibu, Jiri, Mfilu, and Talangai. The challenge has been the limited local surveillance and the lab capacity. They've received some support to increase that, and it's also re-emphasized the need to decentralize the laboratory and to push on the surveillance. But on the other side, challenge is WASH, the access to clean water, which has been the biggest challenge for those community. But the support will be coming in terms of expansion of the case finding and the treatment center, the training of healthcare workers who have not been used to deal with cholera and this outbreak. Next slide. In DRC, we see an increase in the number of cases, or the decrease in the number of deaths. So the outbreak is continuing, but at some point, the response also it's increasing to ensure that we can limit the impact. As you will see, the OCV coverage is now 45%, especially in the high-risk zone that has been vaccinated. The hotspots are the Sud Kivu, the North Kivu, Chopo, Katanga, Tanganyika, Maniema, and Olomami. Some of them are also the same places where we've been dealing with Mpox, but also with measles. So having those different outbreaks in the same environment, or also in some places like North Kivu and South Kivu, where the access is quite complex because of the still ongoing humanitarian crisis, make it difficult to actually manage to get rid of the cholera. But we believe that the multi-sectorial approach will include more humanitarian actors, but also the leaders, the military humanitarian actor will allow us to reach those areas and ensure that we improve in access to clean water. So as per now, the case fatality rate globally is around 3%, but it's above the 5% in 11 out of the 20 affected provinces. So this means that on top of the access to clean water, there is a critical need to support and improve the case management, which is a call for all the different actors, especially those who have access to places where the other actors don't have access. The insecurity, as I just mentioned, the damaged water network and the vaccine supplies constraint, multi-disease, Mpox, measles, and malaria. Those are some of the big challenges that the country is facing to properly control this cholera outbreak. Next slide. Moving to Angola, we are continuing seeing the decrease in the number of cases, stabilizing around 58, which is good evidence of the activity, the action that have been implementing, especially the OCV vaccination. As you can see, 1.94 million of the 2 million target, 97.2% coverage has been happening in the 6 province previous round. So hotspot today, Hulia, where 47 cases has been reported, Lunda as well. The driver remained the same, the seasonal rain and flood, the cross-border movement, the urban slum condition with inadequate sanitation. So we will always link cholera, poverty, and also a bit of the climate change, emphasizes the need for that multi-sectorial approach. Next slide. In Chad as well, we see the increase in the number of cases, and also we can see a small decrease in the number of deaths. So Chad, the OCV coverage is not yet implemented, and the challenge that the Chad has been having is that the cholera is happening in the refugee camp, which is spread to Chokoyan, Adid, and other places. So the main driver is there is no peace. They are bordering Sudan, where there is conflict. You have the mass refugee in influx, which lead to overcrowd the camp with unsafe water and sanitation. So once again, there is no health without peace. When one country is affected, as Sudan, then therefore you will have those displacement, and which will definitely lead to challenge in Chad. As you can see in Chad as well, there is a sharp rise in the cholera case. The deaths have also increased in parallel, as you can see in the curve. So the support that is critically needed is on the surveillance, on the access to water, but again in the case management to ensure that we reduce as much as possible the number of deaths that is being seen in the country. Next slide. In Ethiopia, we are gladly seeing a 75 decrease in the number of cases from 191 to 47 cases. The number of deaths are stable between 2 to 3. We are also appreciate that all spots remain the same, the border of Gambela, the Amara region. So when you look at the curve, you can see that multi-wave pattern in the reporting case. The Holy Water Pilgrimage, the Kwara Amra population movement has also contributed, as well as the conflict and the displacement in the northern region. So whether we are in Ethiopia, in Sudan, in Chad, you always see how the crisis, the humanitarian crisis, is fueling those cholera outbreaks. The expansion of the OCV to new hotspots, including Amara, is critical to ensure that we have a comprehensive and we can accelerate actually the decrease that we are gladly seeing currently happening in Ethiopia. Next slide. In summary, we can say that in the side of Mpox, the decade are going very down by 76% from the peak level. We are moving down, especially in the high burden country, DRC, Uganda, Sierra Leone, Burundi, Guinea, and Liberia. We have some countries where the cases are increasing, including Guinea, but also Kenya is a bit stable, which we emphasize the need to have a comprehensive approach, but to learn from the high burden countries on which action, especially the isolation of the case that we've seen working well in Burundi, to ensure that the country that are facing those new cases also take those action. The vaccine dose, we've reached the bar of the 1 million dose. We still need 3 million dose to ensure that our continent is fully protected. The surveillance remain key, the vaccination as well, as I just mentioned. And next week, we'll have 2 very critical meetings. The one on the 2nd of September, the ECG for Africa CDC to assess whether the Mpox should remain effects. And the 4th, the IHR of WHO will assess whether the effects should also remain or be lifted. Regardless of the decision, it will not mean that the outbreak has ended. It will just mean that we should reduce on some of the activities, but we should ensure that there is a transition guide that the country will receive to ensure that they can include the Mpox within the national system. On the side of cholera, we've learned from Mpox, and because of this model, we will integrate the Mpox within the IMST. The continental plan has been launched. The strong leadership has been shown at the highest level, and that will drive us toward the cholera elimination by 2030. So now, in terms of next step, we'll have that continental presidential task force that will be established, to ensure that we have the multi-sectorial humanitarian approach that will help us to mobilize some resources, including the vaccine that are critical. We need around 10 million doses of vaccine to ensure that the continent is protected in the next 6 months of cholera. The integration of cholera in the IMST is a reality, and as you can see with those presentations, and we will keep on pushing to ensure that we have that one team, one plan, one budget, one M&E framework. Those are not only words, but this is the reality that we are facing in a daily basis within the IMST. With that, I will be happy with my colleagues who are connected to take some of the questions. Thank you.
Thank you very much, Prof. Let's take the first 2 questions. We have one from Tanaka Mrewa of Site Media Health outlet. The question is, have there been notable shifts in mortality rates among patients with HIV, cholera, and TB since the recent reductions in Western funding in Southern Africa, particularly in Zimbabwe? That's the first question. And then the second one is from Ebrima from Gambia Radio and Television Services. The question is, what is the current status of Mpox in West Africa, particularly in the Senegambia region? You can take those 2, Prof. Back to you.
Thank you. Thank you very much for the question. We'll start with the last one on Mpox in West Africa, especially in Senegal and Gambia. On the 22nd of this month, Senegal has reported the first case of Mpox, which is a traveler that arrived in the country. And they've managed actually, one, to detect and also to isolate the patient. So the investigation are ongoing. But since then, so that's already a week, there is no secondary case that has been declared. So that's critical and important to highlight how Senegal, with the surveillance sentinel system, has been able to capture that case and ensure that there is no extension. And the same thing happened to Gambia, where they also had one case, and they've managed also to contain through the isolation and the actual investigation. This is for those 2 countries. Then we have the other West African countries that we've highlighted, the Sierra Leone, where we are seeing the case decreasing. Liberia, we see the case that are stagnating, but we have Guinea. Guinea is also one of the countries where we see the continuation of the increased number of cases. And then we have the challenge that in that country, the test positivity rate remain quite low, not high actually, meaning that the community surveillance is not happening as it should be. Sorry. So on the side of the USG funding, as mentioned some few weeks ago, an assessment, a proper assessment in the continent should have started to assess the real impact of the USG. But what I can mention currently, let me just consult. The major effect that has been captured is actually in the testing and access to medication in those countries. So currently there is no exact data on the number of deaths that has been lost due to the HIV. In the other hand, it's also important to appreciate that though there has been a decrease from the USG, there has been also leadership from the African countries, including South Africa, who has really invested to ensure that their patient gets the adequate care. That has also been the case in other countries, Cameroon, Uganda, and others, to ensure that there is a continuation in the management of the people living with HIV.
Thank you, Prof. We're crossing over now to the floor. I have Predrag from Kosovo Online. Predrag, you have the floor. Predrag, if you can hear us. Okay, let's move over to Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there. I hope you can hear me. Thank you for the opportunity. I wanted to ask for a little bit of explanation on what you think is responsible for the high fatality rate in Sierra Leone. I know you already mentioned it could be as a result of people with pre-existing conditions. But besides that, is there any other factor you may suspect that you think the authorities should look at? Thank you.
Thank you, Kemo. Let's take the next one before Prof comes in. We have Paul from the Lancet. Paul, you have the floor.
Yes, thank you very much. So my first question is this, with this new expanded role of the HMST to cholera, and what has the African government promised to do differently in terms of resource commitment, or is it still going to be, are we still going to be going to the international community to help fund this? Also, what does the projected outlook look like, considering the fact that cholera is not new on the continent and African countries have been responding to cholera for decades, if not more than that? So what is now going to be the new thing that this expanded approach is going to bring on board, and whether there are specific timelines and deliverables for this undertaking? Thank you.
Thank you. Back to you, Prof.
Yes, thank you so much, Kemo and Paul, for the great question. So for Kemo, you were asking what are the driver of the high case fatality rate in Sierra Leone. It's true that we mentioned the comorbidities. We've seen that 79% of the people who actually die in Sierra Leone are also affected by HIV and other comorbidities. In the CPHL lab, they even identified some people who two actually person who died were also positive for HPV, the one causing cancer. So it's one thing to say what is happening, but it's something else to say what are we doing to prevent it from happening. So there has been some investigation to understand properly why is it happening. So impact of the delayed management, control of those patients. So some of the people living with HIV, because of the stigmatization that is added with Mpox, some of them will remain in the community. And then it's only when they are in a severe and advanced case of Mpox that they will go to the hospital. Now, when they go to the hospital, the management of Mpox on one side and HIV on the other side make it very complicated, especially for those patients that were not on ARVs for quite a number of them. That is one. So the second part is that even when the transfer is being done on time, the challenges on the funding has made it difficult to provide the comprehensive management of those patients. But following the support that they received from MST and also the discussion in country with different partners, they really emphasize at three level actually. In the community, you remember that there is that 0 case by the end of August, which also ensure that they can capture the patient in the early stage. Secondly, in the first hospital where patients go to seek care, to ensure that there is an important willingness to support people living with HIV. And the third one is the vaccination. The people living with HIV are put as a priority for the vaccination that is happening in Sierra Leone. So we believe that with all those different approaches, they will be able to reduce the case fatality rate in the coming weeks. Now, the expansion of the IMST. You are right, Paul. Cholera has been there for a while. And most of the time, the way we were responding to cholera, we were having Ministry of Health with the incident management system. They will have their plan, they will have their pillars, they will implement their activity, which most of the time will work on the side of surveillance, laboratory for the detection, case management. But the actual drivers, which is the access to clean water, is not the mandate of the Ministry of Health. So what is changing now is to bring the issue of cholera at the highest level, at the presidential level, so that the head of state will first establish the continental task force And one of the key recommendations of the task force is to ensure that we have presidential task force in those affected countries. So now the president will now ensure that within the response, there's not only the Ministry of Health, but also the Minister of Finance, the planification, the local government, to ensure that cholera is really handled from all the different angles. That is one of the major change. And that's why the launch was not made by the Director General of Africa CDC and or the WHO, but by the President of Zambia, which is the AU champion for cholera. So the major difference is really that we put it at the highest level. So the plan is for 6 months to really tackle the emergency in the next 6 months, while we have the task force that will ensure that at the continental level, we move toward the elimination of cholera by 2030.
Thank you, Prof. We have another question here from Christopher of Deutschland Radio in Germany. The question is, how can new cases of diphtheria and cholera be attributed to the USAID cuts? And then have African countries relied too heavily on this financial support? And what is currently being undertaken to scale up funding? And then which repercussions of the cuts might follow? Those are the three questions from Christopher. I'll now hand over the floor back to you.
So thank you so much, Christopher, for the question. I think we've spoken a lot about the impact of the cuts on the continent, on the HIV, on diphtheria, cholera, Mpox, how it has been impacting the sample collection, the testing in many places. So what is being done is happening at different levels. The first one is at the country level. The country has taken the leadership. I mentioned South Africa on the side of HIV with many other countries. I can also mention other countries that are mobilizing domestic resources so that they can be involved in a response. In DRC, for one example, they are moving toward those innovative funding, taking 1 to 2% of the taxes that will be invested on the response to outbreaks in the country. This is also aligned with the Africa CDC vision to ensure that we change the financing of the health in the continent. We look at the domestic funding. We are going back to the Abuja Declaration 20 years ago, where our countries has signed to spend more than 50% of the GDP into health. We are also talking about innovative funding, where as I mentioned for DST, we have those different approach, but also engaging the diaspora so that they can also contribute. And last but not the least, the blended financing, where we engage the private sector, as Africa CDC has engaged company like Ethiopian Airlines, who are thinking on how they can use a proportion of the ticket to invest in the epidemic fund. So those are some of the initiatives that we really want to showcase so that we change the narrative. We move from USJ cuts where the country are crying toward where the continent is really taking ownership of its health by investing themselves on how they can get the resource and ensure that our community is safe.
Thank you, Prof. Let's cross over back to the floor. We have Anait from Reuters. Anait, you have the floor.
Hi, it's Anait. So we are trying to understand the impact from what's happening in the US, with the CDC there. So I have several questions on that. What is your response to the ouster and resignation of top officials? What impact do the changes have on the ability of global health agencies to coordinate with each other to protect global health? Do you see any immediate impact from the loss of senior staff? What does it mean for agencies like yours when the US Health Secretary is accused of undermining the science that is used for making public health decisions? And do you have any contact with the US CDC? And do you have more details on what happened and when it happened? Thank you.
Thank you. Back to you, Prof.
Yes, thank you. So those are very critical question. But on our side of Africa CDC, we definitely don't judge the movement within the senior people or the people who are working within the administration. What we know is that we work with the people who are there. So there have been some engagement. If you recall, few months ago, our DJ and the leadership went to the US, and then they also engaged at the highest level of the government of US to ensure that the communication continue. And actually, the new model that we are proposing, moving from aid to investment, is very welcome. The agenda of African manufacturing is also welcome because definitely the US, they want the country to be safer, stronger, and so on. We want the same. So by discussing at the same level, this has actually brought some good understanding. So what I will say, just to get back to you, is that the movement that are happening, we have nothing to comment, but definitely we are working with those who are there to ensure that we protect our continent.
Great. Let's take the next two questions. I have Rachel from the Independent. The question is, let me find the question. Hold on. Yeah, Rachel from the Independent. The question is, please can you comment on the ways in which aid cuts are impacting the Mpox response currently, specifically in Sierra Leone? Are there any activities that were possible before which are now more challenging? Back to you, Prof.
Yes, definitely. Sierra Leone, they have something good, apart from many things that they've been doing, is that they have a dashboard, which is public. These dashboards highlight all the resource that they receive from the pledge to the disbursement. So you will see how the pledge that was under the USAID have not been transformed into disbursement. And therefore, they have affected some of the action on the side of community-based surveillance. They started an activity called Find Them All, that is a few months ago, that they were not able to carry on. But after that, the government has managed to invest 1.7 million of their budget into that response. There has also been some support from the IMST, around 1 million, and other partners that has helped actually the country not to have the same amount of money, but to be more efficient in the activity that they've been implementing. And the result that we are seeing, it's a very good example of how a crisis has been turned into an opportunity to be more efficient on how we use the resources that are available by focusing on the most impacted action that has the highest value on controlling the outbreak.
Good. Let's take the next question here. We have one from Richard Akondo. The question is, where are we as a continent in terms of resource mobilization for vaccine doses and PPEs with regards to epidemic preparedness for cholera? That's the first question. And then the second one is, what is our resource mobilization strategy? And is it dependent on member country contributions or international donors, owing to the fact of the USAID pullout? Back to you, Prof.
So thank you so much for the questions. The task force that we are launching, that will be chaired by the AU Cholera Champions. One of the mandate is really to mobilize resources. So the budget for the response is $231 million of dollars for the next 6 months. And this includes also around $48 million for the vaccine. So that includes buying the vaccine, $10 million of vaccine. This is what we will be needed, which is 80% of the 12 million of the people that will be exposed. So now in terms of the funding, where it will come, so we have definitely encouraged and engaged the domestic funding. And that's why we raise the cholera at the level of the president. But yes, we are talking about the African leadership, But the global solidarity, once again, the IMST is led by Africa CDC and WHO, but we have all those partners. And this vision is aligned with the Global Task Force for Cholera Elimination. We have the Gavi, we have the World Bank, we have all those partners who will continue to contribute within the plan. So the mobilization will be led by the task force, who will ensure that we look at all the different angles. And we believe that it will be, for us, a good test, a good opportunity to move toward the implementation of the new financing era that Africa CDC is pushing. Just to remind once again, the domestic funding, the innovative financing, and also the blend funding. So those are part of the strategy that will be used to mobilize the resources to address the issue of cholera.
Thank you, Prof. The next question is from Mark, who is an Associated Press reporter. The question is regarding the 39 deaths from cholera in Chad. Does this include deaths at the community level? And he's asking the question because the number of deaths reported by Chad's Ministry of Health are close to 60. Back to you, Prof.
Yeah, thank you. So I will let my colleague, Dr. Mercy Cheng, who will answer that question. Dr. Mercy.
Yeah, thank you so much, Prof. And thanks for that question. So let me start by addressing the issue around the data coming from Chad. As you know, cholera is quite a dynamic disease. So there's some sort of evolution as the situation also continues to evolve in the country. And definitely the numbers also would definitely keep changing. But as we speak, in terms of the data that we do have coming from Chad, we have seen 6 deaths, if I'm not mistaken, but I'll put the exact numbers, 60 deaths, sorry, if I'm not mistaken, as I'll put the exact numbers in the chat box in a few. However, this is old data because we also hope that more information will be coming up in the weeks ahead on the current situation. But in terms of the disaggregation as per how many deaths occurred in the facility, versus how many in the communities, and this information was not provided. However, we engaged the country to get this disaggregated data, and hoping we'll be coming back to you with more information on the same.
Thank you so much, Mercy. Actually, in the site report for the country, we were seeing, as Mercy just mentioned, is quite dynamic. What we present usually to you are the data that has been received for the previous weeks. As what we are seeing for the site rep, they are reporting 75 deaths. And out of them, 43 are coming from the community with the case fatality rate of 7%. So we will actually triangulate those data and ensure that as we go, you have the proper feedback. But this highlights, again, the challenge that we are mentioning, the need for the surveillance within the community and the need for action to happen in those communities so that the management happen there and not seeing that number of patients that will die within the community. Thank you.
Thank you, Prof. Let's take the last 2 questions. We have Topolina from Triumphant College Campus Radio in Namibia. The question is, community members residing around Katima, Mulilo borders have raised concerns about the lack of supervision and testing for monkeypox among truck drivers entering and leaving Namibia. How can Africa CDC assist in addressing this issue? That's the first question. And then we have another one here from Niang of Group Futures Media. The question is, the first case of Mpox has been reported and treated in Senegal. What collaboration exists between Africa CDC and the Senegalese health authorities? And what concrete support is Africa CDC providing to control the disease? Back to you, Prof.
Thank you. I will respond to the second question on Senegal and leave Dr. Cheng to answer the question from Tokolina. So Senegal is, first of all, a country that has a strong experience on surveillance. They have developed the 4S Sentinel surveillance system. They have a very good network with the support of Institut Pasteur of Dakar, which is a great supporter of Africa CDC. We've been working with them and ensuring that they support other countries, Sierra Leone, for the testing, the sequencing, and so on. So just to say that Senegal is definitely well equipped in terms of capacity for surveillance, but also for management and laboratory. However, Senegal, as all the African country, is a member state. So what happens when a country has a case? We engage them to ensure that we have a better understanding of what is happening. And then we will together decide where are the gaps, what are the needs, as we do with other countries. This morning we were engaging Cameroon and Ethiopia, ensuring that we know where they stand and the support they need. We'll have some country mission in Guinea, in Liberia, in Kenya and Mozambique. So we'll do the same thing with Senegal, and based on the need, they will definitely receive the support, not only for Africa CDC, but from the IMST. Remember, we have this joint leadership of the IMST.
The next question for Dr. Marcy.
Sorry, please, I didn't get the question right.
All right,
So
let me just...
Yes, go on, Director Margaret.
This is Topolina from Campus Radio in Namibia. The question is, community members residing around Katima-Mulilo borders have raised concerns about the lack of supervision and testing for monkeypox among truck drivers entering and leaving Namibia. How can Africa CDC assist in addressing this issue?
Thank you so much for that question. I think that's very important. But there's one thing that we definitely have to be cognizant of. A screening at point of entry or screening drivers coming in and out of the country definitely is not going to stop spillovers into neighboring countries or to new countries that have never experienced outbreaks. So what measures need to be put in place at both fronts? On the Namibia side, we definitely need to strengthen community-based surveillance so that if there's any imported case, we are able to detect in real time and report. And secondly, on the other side of the countries where we have reported maybe community transmission ongoing or sustained transmission ongoing, we also need to build capacity for early detection and quick isolation of cases for proper management. However, if we focus our attention on putting on mounting screening points at point of entries or at airports or by the entry board or the borders, it definitely we may be able to detect one or two cases, but definitely those are not sustainable measures to stop transmissions or cases from spilling over into the country. So Namibia shares borders with several countries that, of course, we know are affected. And most of these countries, we believe, also have put in, who've supported, as Africa CDC supported in strengthening community health workers, or deploying community health workers, and also strengthening community-based surveillance, including event-based surveillance that looks beyond just Mpox, but other public health threats like cholera, which of course they had reported imported cases early this year. So we are hoping that some of these strategies would definitely go a long way to improve and strengthen also Namibia's health system. Recently, we were in Namibia to launch the event-based surveillance guide, which also spans beyond any particular biological hazard, but also looking at also non-biological hazard that would also support Namibia to be able to detect and report these threats promptly. Over.
Thank you, Dr. Marcy. And with that, we have come to the end of the briefing this week. I'll pass over the floor back to Prof to close the session. Back to you, Prof.
Thank you so much, Director Margaret. Thank you, Dr. Mercy. Thank you to all the colleagues who are all around. You don't see them, but they are all around to ensure that we have adequate support to give you the actual answer to your question. And thanks to you, really. We keep on telling the same thing on the support we get from you, the journalist. not only on ensuring that the right information is communicated in all the country where you are coming from, but also through your question to keep on ensuring that we have accountability to you, to your leaders, and to our communities. So we thank you for that. Next week, as mentioned, we'll have the ECG meeting on the side of Africa CDC to assess the facts. And we also have the IHR meeting from the side of WHO to assess whether the facts should be lifted or should continue as Mpox is concerned. So we'll be giving you feedback definitely next week on Thursday. And also we are moving deep dive on the response to cholera using the IMST, following the recommendation of our head of state and the new plan that we have. So we will count on you, keep counting on you for the following up, supporting us, and ensuring that we keep on sending the good information to our community. Thank you.